Good. So we have Dr. Hawthorne Smith, is a licensed psychologist and the director of the Bellevue Program for Survivors of Torture. He's an associate clinical professor at NYU School of Medicine in the Department of Psychiatry, as well as the president of the National Consortium for Torture Treatment Programs. Dr. Smith received his doctorate in counseling psychology with a distinction from Teachers College of Columbia University. Dr. Smith had previously earned a Bachelor's of Science in Foreign Services from Georgetown and an advanced certificate in African Studies from Duop University in Dakar, Senegal. He also has a Master's of International Affairs from Columbia University International School and Public Affairs. He's facilitated a support group for French-speaking African survivors of torture for the past 28 years. He speaks extensively at professional conferences and seminars, providing clinical services for survivors of social political violence and enhancing cross-cultural clinical skills among therapeutic service providers. I want to say that I was thrilled that Dr. Smith accepted our invitation to come and speak with us today. First, we are of no relation. Our names are very common, so let me just say that. But I was introduced to the Survivors of Torture Clinic when I was a medical student at Bellevue, and I can say that it was a very, very informative time period in my training, and so I'm very excited to have him come to speak with us today.
Thank you so very much. I really appreciate that. This has been a beautiful experience this morning. It's really nice when you come to a conference and as each speaker goes forth and you're just like, I'm not alone out there. There are other people who are observing and beyond observing, feeling and understanding so much of what is going on. And my dad used to always tell me growing up that, two watchdogs are 10 times more powerful than one. I didn't always understand the math, but sometimes when you know that there's someone who's watching your back, that if, that you can be proactive about doing the things that you need to do. And that even if you have a really rough day and you need to sort of howl at the moon, that there's someone else out there who understands what's going on, and it really makes sense. And so thank you so very much for inviting me and for the important work you're doing. And I've been going through a little bit of exposure therapy this morning. Every time I hear someone say Dr. Smith, and I sort of like react like I have to do something. I'm calming down and I understand that they're referring to you, Dr. Teresa Smith. Thank you so very much for having me. If we could move to the next slide. I am here representing the Bellevue Program for Survivors of Torture. So very briefly, we have been in existence for, my goodness, we're going close to 30 years now. We have served more than 6,000 men and women from around the world. I think that we are up to 117 countries represented in our client base. And perhaps, what is most important is that we really take a resilience-based approach. It's holistic, interdisciplinary, all of these things that we're going to touch upon in order to help us to really rebuild the bodies, the minds, the spirits of people who have been tortured or persecuted. I like these two pictures that are here because one sort of shows the modern aspect, the evidence-based practice aspect, the training that we do. And you see that in sort of the nice architecture and everything up front. But then also Bellevue is the oldest public hospital in the United States. We've been up and running since 1734. So not only are we going to be talking about evidence-based practice, but also practice-based evidence. And, and sort of the wisdom, the common sense that we get from our clients and listening to them. I know earlier, Umberto, you talked a couple times about agency and, these multi-directional paths of communication. And I think that is so very important. And one thing I'd like to say just before we jump into the next slide is oftentimes when I'm doing presentations like this in the community, one of the questions I get is, who are these survivors of torture? It's almost like it's posed in a kind of, to use that word, exotic. Who is this exotic population? Who are these people? And one of the things I really need to underscore is that this is not about them. This is about us. And if we go to the next slide, oftentimes when there's more time, I will go through the audience and ask questions like, have you ever voted in an election? Do you identify as a woman? Do you have an identifiable racial or ethnic background? And all hands should go up with that. Have you ever, written a blog post or something like that? I used to say writing a letter to the editor, but that just shows how old I am. Yeah, as you can see these things here, and people raise their hands. And after this exercise, I let them know that if you have raised your hand to any of these questions, I can say that the people we are working with are people just like you, just like us. We see so many clients who have been mistreated because of their advocacy for human rights issues, for providing medical services across ethnic lines, across political lines, women who have been caught up in the area where warfare was being put forth. And we understand that in the sort of quote unquote modern ways that war is prosecuted, sexual violence is just becoming more and more of an issue and part of the way that war is waged. All of these things. So this is not, again, about an exotic other. This is about us and a sense of shared humanity. Next slide, please. So what are some of the extreme challenges? We look at multiple losses. Another exercise that I do oftentimes when we have more time is I will ask people to write down on a piece of paper maybe 3 or 5 of the things in their life that are most important to them, things that make life worth living. And it can be anything. And people will take the time, I'll collect the papers and anonymously start reading them. And you get things like, perhaps someone is a spouse or a parent, or it's about their professional or religious activities, their academic achievements, their health, all of these different things. I'll take the papers and sort of a fit of overblown theatrics, rip the papers up and ask the people in the audience what their life would be. What would you imagine if those things you had written on a piece of paper were violently and purposely ripped away from you and that you were currently unable to reclaim them? And then we look at the sort of ongoing effects, the reinforcing effects of trauma. We're not just talking about something that happened, someone had a really bad day 5 years ago in the Democratic Republic of Congo. There is that social dislocation. Perhaps there is open warfare. There is some sort of direct trauma, physical, emotional, spiritual. People are often internally displaced in their home country, living and hiding. Perhaps often they will then cross the border into a neighboring country. And this is by no means scientific, but in my experience, I find that 9 times out of 10, when somebody is fleeing a war-torn, violent, chaotic, impoverished situation and goes across the border, that they are arriving in a context where there is poverty, perhaps social dislocation, perhaps they are even indexed as those refugees who are coming across the border. It is not necessarily a safe space. And for those of us who have had the opportunity to do any work in a refugee camp or what have you, the endemic public health issues and all of that, but somehow they make it from there. They make it here to the United States. Some people coming on visas and flying, others stowing away. So many people coming by the southern border now. We can talk about that. But then as they come into the United States, and the resettlement and the pressures. And some of our speakers have spoken already about what they're hearing on the news. I'm, continually running my group and seeing people, and people are terrified right now from what they're hearing about mass deportations. Is it going to start in the shelters where we are, in the Hercs? What's going on? How do I protect myself? All of these things, the asylum process. And it was beautiful, Sabrina, when you were talking about that. And, one of the things maybe we can talk about later, another thing that predated some of the things you talked about was this whole changing from first in, first out, FIFO, to last in, first out. This happened during the previous administration and how this has sort of turned things upside down. So all of these stressors very much serve to keep things alive, to keep the trauma alive in the present. So we are not, we can use PTSD as a useful diagnosis, and it is, but are we really talking about something that is post? And when you think about the things that maybe you would have written down on that piece of paper, the things lost, the recurrent losses, would it change your mood? Would it affect your sleep? your ability to engage with people? Are we talking about a disorder, like there's something wrong with you? Or are you a person that is dealing with an abnormal situation or sick circumstances? And people will respond to these stressors in many different ways. Next slide, please. So, as been mentioned before, the physical and the emotional scars of torture. These are two pieces of art we got through the IRCT. Oftentimes, when I do these presentations with some of our PCPs, we have what they call the quote unquote the gory slide presentation. I'm not going to be doing any of that this morning. But yes, we are dealing with people who have dealt with amputations, who have burns. We very much work in an interdisciplinary way. So we work with dermatology. We work with orthopedics. Of course, we're dealing with folks in the emergency units, and we will talk about that. OBGYN for incidents of sexual violence, and also women who have endured the female genital cutting and mutilation. There's a lot going on physically. But one of the things I want to say is that some of the folks who abuse others have become more sophisticated. And I hate to use that word because it feels like a compliment, but doing things that don't necessarily leave the physical marks. So, for example, a client who comes in and may describe a mock execution that they went through, who can talk to you in great detail about what it felt like when the barrel of the gun, the coldness of the iron, or what have you against their temple, being told to say their last prayer or say their last words. And when that click happens, no bullet comes out, there's no scar. But perhaps when I'm dealing with someone and they're talking about their trauma-related nightmares and all that, it's that click that wakes them up in a panic every night. It has been said that it is easier to kill a microbe than it is to kill a memory. And the way that the physical and the emotional feed upon one another is really something that we will move on to in the next slide as well. Um, so common reaction to torture and refugee trauma. There would be a lot more lobes on this flower if I was a little bit better with my PowerPoint, but even just looking at these 5 things, the important thing for people to take perhaps from this slide is that none of this happens in a vacuum. These are not distinct areas of people being able to put forth their behaviors. We live in the center of this flower, that brown circle that is right there, where the cognitions, the spirituality, the emotions and everything, the behavior, so for example, if I'm working with a young man from Guinea who has been, horribly traumatized, cannot sleep, he's having nightmares and all that, but he's engaged in social services, case management. But because he didn't sleep, perhaps he's waking up with a headache. Perhaps he falls asleep in the morning because he can't fall asleep at night. He misses his appointment, or he's late for his appointment for a job interview. And people say, oh, is he reticent? Is he resistant? What's going on here? Perhaps the person is then sitting at home and, you know, um, what it is they're thinking about, the emotional really kicks in. What is wrong with me? Why can't I do these things? Perhaps they will self-medicate. Behaviors might change. For many New Yorkers, drinking 2 beers is not a big thing. But for many of my Muslim clients, for whom drinking alcohol is haram, but they need to do something so that they can at least get to sleep, it changes the behaviors. It can really mess with the familial interactions and relationships. And the physical, again, there can be those things that are directly linked to the trauma, but other times there can be sort of the manifestations of the emotional things. I have many, I've had a few clients from West African cultures, particularly among Malinke people, who, when they're feeling stressed, will say, it feels like there are ants crawling on my scalp. It's a physical sensation for which we can't find a biological etiology, but all these things are linked. So I just wanted to say that. If we can move to the next slide. So that's sort of at the individual level and how one is, sort of dealing with this in and of themselves, but it's also relational. So for those of us who are working with clients as medical professionals, as social service providers, as advocates, Trauma affects a person's ability to process information. On the previous slide, we looked at cognition, and we can talk about traumatic memory. A half hour is tough because it's that whole balance of breadth and depth, but the cognitions are changed. The ability or even the willingness to talk about those memories, to relate to other people, to have that sort of sense of trust. And, one of the things, and maybe we'll touch on this a little bit earlier, I think, Camila, you mentioned trust and distrust. And a quick little anecdote on that. I was working, this is a long time ago, a couple of decades ago, working with a woman from Cameroon who had been from an elite family. Um, she actually had bodyguards from the time she was a little girl to a young adult. And when there was an attempted coup d'etat and there was a reversal of power, the first people who turned on her were her bodyguards. And here we are in New York City talking about trust. And she said to me, there is absolutely no way you can earn my trust. Even if you say all the right things, even if you do all the right things, that's exactly what my bodyguards did for 20 years, and ultimately they betrayed me. So there's nothing you can do to earn my trust. I responded with silence. One, I thought it was appropriate. Two, I had nothing. um, but after a few minutes, she spoke up again and she said, although there's nothing you can do to earn my trust, perhaps it's something I can offer because I really need help. And so since then, it has really sort of altered how I view that. I know that there are things I can do to destroy someone's ability to trust in me, but I know I can't earn it. I need to look at it as a precious gift that is being offered by the client. Trauma affects her ability to think about the future, feelings about the world, about him and herself, and it is really going to impact the way that they engage with us. We need to keep this in mind. Next slide, please. So again, stepping out one more level in terms of social functioning, community functioning. We look at education. I'm one of two Dr. Smiths on this call. It was a huge thing when I got my doctorate in my family, first one. But if stuff hits the fan here, and if you're following the news and whatever, there's potential that stuff could hit the fan here. And I fled. Let's say I went to Haiti. My Creole is so non-existent that not only am I no longer Dr. Smith, but I'm now functionally illiterate. Um, and this we see from many of our clients who have been targeted because of their leadership roles in their populations, but now they're starting back over, learning the language, going into GED courses, social service provision. Do we even want to talk about the HERCs and the shelters? We probably need to, but I'm just going to go through that. And also this sort of stigma that may be really affiliated with someone who has been a leader in his or her family, and now even just taking a Metro card to get back and forth. We've had clients who have walked from South Bronx down to Bellevue because they did not want to take that sort of assistance. So we can talk about that. Vocational, professional. Again, you never know who's driving your taxi, your Uber, your Lyft. You never know who's standing outside of that, 99-cent store or washing cars in February, and the social functioning, all of this. So the impact of trauma and everything is beyond just the person, it's relational, and it's also in terms of engagement in society. Next slide, please. So bad news so far, right? What a bummer. You shouldn't have invited me, but there is hope for our clients and within what we do. Again, with those lobes, with all the challenges, they're the lobes in terms of ways that we can engage. And again, our clients live in the middle. So someone comes to our program at Bellevue, they might not initially be so interested in psychotherapy. It might be foreign to them, or it might even be stigmatized. But perhaps they are very interested in, if we can just go back, thank you, in the legal services. About 94% of our client base are either asylum seekers or will be in the asylum process. And I'm very happy to report that in our time, we have now been involved in over 1,600 successful asylum adjudications. Our success rate for our clients hovers around 94%. And as Sabrina was saying before, nationally, it's a minority of people who get there. But our interventions, not only just in terms of providing medical, behavioral health sort of affidavits, but also helping people to tolerate what is intolerable to get them to actually be there for their asylum hearings. But it might be that they're meeting with our legal representatives who notice that, you seem really isolated. Dr. Smith runs a group for French-speaking African survivors. Perhaps people who are getting services in one of these areas are more, and they see that there is actual some positive benefit, are probably more amenable to taking referrals and engaging in other services. So the spiritual engagement, the social legal support I just talked about, and the medical, the behavioral health, all this working together. And as was mentioned before, the community contacts, it's all very important. Everything we do, there are so many challenges, but there are so many real and tangible ways to bring positive benefit. Thank you. Next slide, please. So for those of you working in the ER, those of you forever, this in 2018, I was in Pittsburgh soon after the horrific attack at the synagogue there. And one of the things that one of the psychiatrists was speaking about, and the MDs were talking about a review of systems with their students, and normally, respiratory, this, that, and the other thing. But they really insisted, they encouraged their students to think beyond that and to include in the review of systems a review of experiences, the review of context, the review of feelings. Not, again, that these are things that are extraneous or adjunctive, but truly part of the psychiatric and medical functioning, that it really goes together. It's part of overall health. And the founder of our program, Dr. Alan Keller, he is very fond of saying, and I learned this from him, that if he only had one question as a primary care doc to ask the survivor who's in front of him with various medical things, he would ask, "How are you sleeping?" It's an open-ended question, but when we get that, it opens so many doors. Is it insomnia that they can't get to sleep? Is it interrupted sleep? Are there nightmares? What's going on? What's the context? I can't sleep because I'm in the herks and it's too loud. I'm too afraid. Any sort of thing to help to get us in there. And that we need to normalize the conversation. As I was saying before, we want to avoid stigmatizing or minimizing, and also understanding that the patient is the best determinant of that pain or distress. Thank you. Next slide. I'm sorry for doing the New York speak at you really, really quickly thing, but trying to get through a lot. But in terms of like approach to the patient, and I've heard trauma informed mentioned a number of times. A couple of things I just wanted to mention is around safety. There's the physical environment. I don't know if many of you have come to Bellevue, Kings County, kind of similar, but Bellevue, I'll speak about it. First Avenue, all the sirens and ambulances and this and that. We have our forensic units. So we have, New York's boldest are there. We have police. We have this. We have had clients come to our hospital. And because many times human rights abuses are perpetrated in civic institutions, police barracks, military barracks, and hospitals, we have had people come in, turn right around. It's just been too activating for them. So sometimes, even being able to meet somebody at the front door to help guide them to where our offices are, to make sure that we try to make it as comfortable and what have you, in the physical sense, but also anticipatory guidance, letting folks know what they can expect from our engagement, what it is we can offer, what it is we can't offer or can't promise, and allowing them to really sort of take the lead. This is around empowerment. I think that earlier, Umberto, you had spoken about agency, that this is a partnership. This is not a hierarchical thing where there's this all-powerful helping person and then this helpless victim. And in fact, our program is named a program for survivors of torture because we feel there's a huge difference between survivors and victims. Any of us can be a victim, wrong place, wrong time, wrong circumstances. But to be a survivor is really about, it's a comportment, it's a way of trying to overcome that, to not allow folks who would want to extinguish our flame to keep that going forward. And I think that in the interdisciplinary way we look at this, one soundbite I hope you take from my comments today is that it does not have to be therapy to be therapeutic. Okay. There are so many ways we can engage with clients that help them. And again, it goes back to that model that any sort of tangible benefit can feed back and feed into the other realms of functioning. Next slide, please. So we talked earlier about culture and culturally syntonic interventions. This is a whole speech and whatever I like to, or training that I give, but I'm just going to say a couple things. For example, the Francophone African support group that I run. We are now in our 28th year. It's rare to have an outpatient group at a hospital here that goes past 18 months or something like that. But this is 28 years because it has been something co-developed by our clients. And it also allows them to be part and parcel of the healing process for other people, that they get the sense that they are not just needy, but they are needed. They are seen, as we were talked about before. And again, that notion of agency, that it has really become a community within our larger community. They actually call the group the Baobab, because in many traditional cultures, and there's, you could maybe say the cotton tree or the banyan or what have you in different cultural contexts. But people gather outside, they share their fears, their victories, their defeats, and help one another, again, giving them that agency. And then what we are doing is adapting what we do in a way that will be for the next slide, please. All right, so there are a few things here. I'm not going to get to all of this because we're running, I don't want to go too long, but again, looking at the power of an empathic human relationship, we all come in with our particular expertise. But as a psychologist, I don't walk into the room with Freud or Adler or any with that. Lawyers don't come in with, Perry Mason. I drew a blank. That was the first lawyer that came to my head. But we do come in as caring, empathic human beings. That is our healing instrument. We talked about the incredible gift of trust. And also, even for some clients we get many people who are not actively suicidal, but perhaps it's more of the philosophic, what is life worth? Where do I go from here? Am I less valuable than others? And really looking at the notion of purposeful existence. And we have clients who tell one another, please do not give the victory to those who have oppressed you, who have oppressed your population, who have oppressed your family. Living well can be the best revenge. And sometimes that sort of motivation to engage in the healing process can be the difference of someone actively healing or just sort of laying back. All right, one thing I'll say here, rien n'est facile, mais tout est possible. Nothing is easy. Dealing with the shelter situation for people who are here with their kids, getting them enrolled in school, obtaining their insurance so they can get our sort of services. None of this is easy. Learning the language, not easy, but it's all possible. And it's one thing for me to say that, for us to say that, but again, within the community, when they're able to see these examples of people who have been walking down this path, and they can say, okay, if it's been possible for them, perhaps it is also possible for me. Again, that engagement. Next slide. And I think that this last story, oh, two slides, right? But this one I just wanted to say, wounded healers, that this work is not easy. I don't know if there's anyone out there that feels that they don't have enough resources, enough time, or you're hearing dramatic stories and all that. I think that's something we all share. Again, this is a longer lecture, but I just wanted to share this photo. I was actually going to speak on these issues in Dar es Salaam, Tanzania, and I was thinking if only there was some kind of image that I could put forth to help people to see that we have to take care of ourselves in order to take care of others. And as we were coming off the ferry, I noticed this rescue boat that is rusted out, has holes in it. It is no longer seaworthy itself. So this boat can't even go into water, let alone rescue other people. And I think that we need to keep that in mind. And yeah, I was kind of here last night, leaving work, but I went and played music with some of my friends. I play out here in New York and play professionally. And I was really not wanting to go, but I found, as I always do, it's almost counterintuitive, that sometimes going out and finding ways to sublimate, finding ways to engage, no matter how tired we are. And I wanted just to come home and grab my remote control and watch some baseball. I went out and it was such a healing thing. But we can talk more about that, hopefully. Last slide. Yeah, as I was saying, about the active engagement in healing. There was one day we had a group session, and there was an escaped slave from Mauritania who was really struggling. His family was in hiding. The asylum process wasn't going quick enough. He was distressed, and he asked the question, what are the qualities, what are the characteristics we need to change the world, or at least to survive in the world? And as a group facilitator, I said, this question is so profound, there's no way they're going to come up with a consensus. I was wrong, as I frequently am. And the 9 people came up with 3 things: la sagesse, le courage, et l'espoir: wisdom, courage, and hope. They went further, and they explained to me that if you have 2 of these 3 characteristics, no matter which 2, it's insufficient. Because you might be a courageous and hopeful person, but if you lack wisdom, perhaps you'll go about your activities in a way that is ineffective and you may fail. If you're a wise and hopeful person, but you lack courage, perhaps you will just stay locked in a prison of inertia and not act upon what it is you need to do. But for those of us doing this work, we know that our client base has the wisdom. And I'm not just talking about advanced studies, but a cultural wisdom, l'éducation de base, as my French speakers would say, that they bring with them. And the courage, again, think about what your life would be if those things had been ripped up, if you were in these circumstances and came here to New York, to the States, to start over at zero. We don't even have to talk about courage, but hope. They let me know that hope is extraordinarily difficult to hold on to. I figured that was it, but they went even further. And they explained that hope is not so much something you have, hope is something you do. It is an active capacity to hope. It's a comportment, it's an attitude. Someone has said that hoping is actually a discipline. And perhaps most importantly, that capacity to hope is something that can be shared. And then when that capacity to hope is shared, then you can use the wisdom. Then you can use the courage that is already there. They explained all this to me. My head was like exploding. It has changed the way I view the work I do, the work we do in the group, the work that we do writ large. And so I wanted to leave you with their words of inspiration. And hopefully this will be helpful as you go forth doing the very important and challenging work that you do. Thank you so very much.
Thank you. Thank you very much, Dr. Smith. Thank you so much.